Good morning, good morning, good morning. Welcome to Calgary Unitarians. My name is Susan Ridley. A lot of you know me, but some of you may not. And I just want to say I'm so grateful to be here. Don't worry about the mask. It's a common head cold, but there you go. You go camping for a week, you come home sick. What can I say? So anyhow, just thank you for coming. I don't see any new faces, I don't think, yet. And just in case you do need to know, there is a washroom straight through that door that's handicap accessible as well. And I'm pleased to introduce, and I will also acknowledge that we are sitting on Territory 7, or Treaty 7 land, and Métis Nation, I think it's 5 and 3 now combined. And we just need to remember to do our best to steward the land as the Indigenous peoples did for thousands and thousands and thousands of years. I'm very pleased to introduce Kira Gunn, our speaker today, who is the current chair of the Calgary branch of the Friends of Medicare organization here in Alberta. She is a longtime political advocate and has been a candidate in two federal elections. And I've gotten to know her through my political work through the NDP. And I can speak very highly of her skills, her knowledge, and her ability to communicate those skills, that knowledge in a way that is accessible to everyone. And she is one of the most kind, caring, and responsible and brilliant people I've ever met. So I turn it over to Kira Gunn.
Thank you, Susan. Everybody can hear me all right? All right, I am just gonna pull up on my computer my slides because I have some notes. There we go. Yeah, so I'm hoping to do presentations like this to different groups because Friends of Medicare, how many people in the room have heard of Friends of Medicare? Okay, a little more than half. So if you don't know about it, it is a nonprofit public healthcare advocacy group out of Alberta. There's a network of similar groups across the country. It's the Canada Coalition for Healthcare, basically, and they're all connected. But Alberta does seem to be the most pressing issue right now. And so all eyes are sort of on what's happening in Alberta right now, particularly with Bill 11 that was passed last November. So I'm going to do sort of a broad talk to kind of paint a whole landscape picture. I only moved to Alberta in about 2018, so a lot of this was research for me and not necessarily my own personal memory. And then what you'll kind of see is as I go through a bit of a history, it'll get a lot more peppered after 2018 because I'm a lot more familiar with those years. But I think it's also when a lot more stuff has happened as well. So I'm going to start with sort of a picture of healthcare and public healthcare throughout Canada since Confederation, very, very broadly jumping ahead to the last 6 or 7 years. And then after that, I'm going to try to really focus in on Bill 11 and another bill that was passed recently, I think it's 26, and just the impacts of those on Alberta and Canadian healthcare. And then just try to talk about how it actually compares to healthcare systems in other countries, because we do kind of hear that the goal is to move to more efficient healthcare systems that other countries have. So I want to actually show you what those other countries look like. All right, next slide. So sorry, some of these slides are a little dense because I'm going through a history. But if we talk, basically 1867, I think we all remember from history class, this was when the Dominion of Canada was formed through the Constitution Act. And basically Section 92 of this act designated different powers to the federal government and provincial governments. And one of the jurisdictions that fell to provincial governments was healthcare, and I think education was one of them. Basically, the jurisdictions that we have now have sort of always been in place. And of course, Alberta joined Confederation in 1905, so became a part of this system that had healthcare delivered through the provinces instead of the country. In 1934, so the United Farmers of Alberta, how many people here know that that used to be a political party that was in power, right? So as an outsider to Alberta, that wasn't something I knew until I moved here. And then, you see all the UFA trucks and billboards. That used to be a very socialist political party. in Alberta. But when they were actually the governing party here, right before an election, they proposed this act, the Alberta Health Insurance Act, that would have given universal healthcare coverage to Albertans. Now, the Social Credit Party was elected before it was able to actually pass through, and so it was never enacted. But it would have been very, very progressive for its time. So there was universal health care in some European countries at that point, but Alberta was hoping to institute it at that time. 1950, a sort of hospitalization scheme was implemented in Alberta, so nothing totally formal, but trying to provide free access to hospitals for mostly emergency care. And then 1969, Alberta does adopt a universal health care plan closely following Saskatchewan's plan. And then it wasn't until 1984 that it got enshrined in Canada under the Canada Health Act. So I think we're all kind of familiar with this. It did essentially legislate federally that everybody should have reasonable care access to health care in Canada, to quality health care, and again, regardless of income or geography. So even people that live in rural jurisdictions should have access to at least comparable care. Yeah. I believe it was a minority conservative. Does anybody know who was actually in power in 1984? Yeah, it was enshrined in that act as far as like how the federal government would oversee this, is like how it would have some sort of federal jurisdiction. Like that was the Canada Health Act. So that was like when it was officially passed. But it was basically in all provinces before then. It was just a matter of like, how do we make sure this thing, like this stays? So like part of the Canada Health Act was that the federal government could use levers. Like the federal government at the time would fund 50% of healthcare for the provinces, and that if provinces weren't abiding by this act, the federal government could withhold payments. And that's how it would enforce it. It was just like, you're not gonna get this money. And so it would be a huge incentive for provinces to actually fulfill this act. But if anybody wants to look it up and grab it for me, please do. And just holler. But so I think the gentleman was saying there was an election in '84 that might have changed who was it Mulrooney at the time the Health Act passed? Yes? Okay. So, all right. So that's what I thought. It was a conservative government that had passed it, but with it was unanimous though. It passed unanimously in the House. So all the support. Okay. So I want to jump ahead to the 90s. So now we're going to go through sort of a little bit of timeline of different premiers throughout Alberta. So Klein was before my time. I never got to experience in Alberta under Ralph Klein. I know. So 1994, there was a huge slash to healthcare spending. So before 1994, and I got some notes here, Alberta was consistently the, I think, top 4 or even second top spender on healthcare. Right? Alberta's a very wealthy province and could afford to do this, and Alberta had been renowned for having some of the best healthcare in the world. When Ralph Klein comes in, he slashes healthcare and starts bringing it down to bottom 3. So I'm talking about the provinces. I'm not talking about the 2 territories at the time, but basically per capita funding just got slashed pretty aggressively. And then just a lot of austerity measures taken that really impacted healthcare. So the Calgary General Hospital was demolished. That's a wild thing for me to think of somebody doing. That's a huge waste of money, but it was done to save money. So in 2000, under Klein's government, Bill 11 was passed, the Healthcare Protection Act. It met a ton of resistance and protest throughout not just Alberta, but the country, because what this essentially did is it gave private clinics the right to perform, so private surgeries were already occurring, but private clinics the right to perform surgeries that required an overnight stay, so that higher level of care, and that was unprecedented in Canada at the time. So Alberta was the first province to bring that in, and there was a lot of friction. And several years later, So there was this policy framework paper that was published. I forget the name of the author of it, but there was Klein was hoping to bring in this third way approach to healthcare, which would have been this massive revamp of what public healthcare looked like in Alberta. Three of the directions of this paper I really want to highlight, though. It was delivering more services through private surgical facilities, was direction 5 of this framework. Direction 7, implementing savings account and private insurance. Oh, sorry, I wrote some of these notes last night. Private insurance and that should say like cover public healthcare, to cover expenses of public healthcare, or what was at the time deemed to be public healthcare, because it wouldn't have been anymore. And then direction 9, permitting physicians to work in both the public and private systems at the same time. So if you're familiar with the current Bill 11, some of those things should seem familiar. And again, this was stuff I did not live in Alberta at the time, so I wasn't paying attention to this. I certainly would have been old enough to pay attention to this, but maybe not thinking so much about healthcare at that age. But at the time, Stephen Harper was the prime minister. He had a minority conservative government, but it was a conservative government. And Stephen Harper told Alberta that we will cut your federal health transfers if you bring these policies in. So this was never enacted, and then Klein did not run again after that, so none of this ever came to. But these 3 directions were the prime pieces of this, and a conservative federal government said this is too far, this is too extreme from our public health care, we will cut your federal transfers. So, what's that? Well, they didn't enact those things though, right? Federal transfers had been cut for sure, yeah. Yeah, I was living in BC for shortly after that, and I remember talks because of all the private healthcare being offered there that federal transfers were being cut. Okay, so we are going to just race through the next 12-ish years. So under Stelmach, Redford, and Notley, in 2006, Stelmach is elected as premier. He actually brings healthcare spending back up to about the rates it was before, like per capita, so it would be the second highest in the provinces. And it was generally only Newfoundland that was costing more per capita, and I think largely that would be more of a population density and like scale issue than, you know, Newfoundland, I say it different every time I say it, than Newfoundland, you know, providing significantly better care, right? Newfoundland was not a particularly wealthy province at the time, and as we know, a lot of people from Newfoundland were actually coming to Alberta. So it would have been just because it's harder to have a robust healthcare system when a population is so small. But yeah, Alberta was basically the top spender in healthcare with Stelmach. And then that progressed through Redford and then through the Notley governments. So they all had fairly similar approaches to public health care. There's no massive aggressive changes at those times. Aside from, in 2009, the healthcare premiums were eliminated. So I was paying them in BC at the time, and I think they were eliminated after. But they, you know, just that payment that we were making to access healthcare, it just is rolled into our taxes at this point. And in 2018, I don't know if you remember, but this was kind of a big deal. Alberta was ranked as the second best integrated healthcare system in the world. So it was like a top-ranked healthcare system, basically being compared to entire nations. So Alberta was up there with full countries in how they were delivering healthcare. All right, so enter the Kenney years. So some of this history is going to get maybe a little bit more dense. So I guess one of the changes that the Notley government did want to bring in was the super lab. I'm sure most of you have kind of heard of this. So now we're getting into more recent history. So this is going to be a refresher. That super lab was supposed to take all of your clinical testing and center it out of Edmonton in a centralized place. So that it would make ease of information to physicians. You would know where to go, you would know where to send things, everything would get tested there and then results delivered out. It was supposed to sort of streamline how diagnostic testing was done. Basically, as soon as Kenney's government was elected, they canceled the super lab project. DynaLife was providing a lot of the testing. It wasn't all of it, there was still some public facilities. But largely it was, you know, this company DynaLife, and so Kenney's government was like, you know, this private company is doing a fine job. We pay them with public money to privately do this. It's working great. We're going to keep this system. About $30 million had already been put into building the super lab, but it was just canceled. And shovels were in the ground, and it was basically just canceled on like day one of the Kenney government. And then things start getting a little bit chaotic with this government, particularly in the early years. So the physicians were in negotiations with the government at the time to redo their pay. I think physicians were at one point the highest paid in the country because people in Alberta were the highest paid in the country. And that was starting to not be so much the case. But during those negotiations, Kenney kind of just tore up the agreement and imposed a new compensation agreement on doctors without consultation. And then COVID hits. So one of the first cases is identified in Alberta, and everything kind of goes into chaos. So as a result of the physicians and surgeons basically saying, like, there's no reason for us to be in Alberta, it's so expensive to run a medical facility, we're going to leave, like we can't stay here. So this is something I didn't know, but the health minister, Tyler Shandro, basically directed the Alberta College of Physicians and Surgeons to change the standards of practice and basically require that for a physician to leave their practice, they have to give 3 months notice, and they basically have to make sure that somebody is going to replace them. So in a province where it's become very difficult to attract physicians, and they're largely leaving this province to go work elsewhere out of this lack of respect that they felt they were experiencing, is essentially making it impossible for doctors to leave. And then shortly after, Shandro announces that they're basically going to start outsourcing all of these frontline healthcare jobs, like a lot of the service jobs. That actually resulted in a wildcat strike that pretty aggressively pushed back on this, which is just kind of interesting. And then COVID is in full swing, and throughout 2021, COVID basically hits. And throughout that time, we had probably louder in Alberta than anywhere else. Really loud calls from frontline workers, physicians, nurses saying that like our healthcare system is going to break, like it is broken and it's not going to be sustainable. So just basically warning signs going up 5 years ago about the cracks in our healthcare system. All right, so now we're going to jump into the Smith years, and as you might imagine, there's a lot of slides here. So pretty quickly, I forget, it was fall of 22 that Smith did get appointed, I believe, as the premier, as the leader of the UPC. Pretty quickly, she fired the entire Alberta Health Services Board. So it was in December 22, and I think it was a contract that was sort of already in place before she stepped in. But this contract to now have DynaLife oversee basically all of these community medical services lab testing, like the stuff that was basically being done through Alberta Precision Laboratories, gets sold out to DynaLife. 3 months later, DynaLife basically goes back and tells the provincial wing that we're bankrupt and we can't do this anymore. And at the end of the year, DynaLife is nationalized by Alberta Health Services. So, it kind of goes back to that cancellation of the super lab and basically saying, no, DynaLife has got this, but DynaLife obviously didn't got this because it was not capable of actually doing all of this testing. So it got nationalized. This ended up costing Alberta, I think, over $100 million. But they had to buy DynaLife back from itself, so to bring it back into the Alberta government. That was a cost of $100 million. And so compare that to a few years before, they were going to buy out DynaLife for $50 million. And so essentially this has just been this like massive wasted cost. All right, 2023. So this is when some of the really, really big aggressive changes started coming in. But there was announcements that this integrated healthcare system that was world-renowned was going to get dismantled. So Alberta Health Services was going to get dismantled into 4 corporations. Shortly after, in 2024, we hear that, Alberta's not going to join the National Pharmacare Plan. I think I missed the piece where we were, oh no, that's on the next slide. Oh, I have a duplicate slide, that's why. There we go. Sorry, can you jump ahead to the next one? I duplicated the slides and added a piece. There we go. So so we're not going to join the National Dental Care Plan. Alberta's not going to join the National Pharmacare plans. And again, these were plans that basically had no cost for the province to join. They were just like the federal government was going to cover the costs and the province would just become part of these plans. But there was no intent to join, just basically saying, we have something better here already, so we don't want to be a part of it, just give us the money. In 2025, Alberta again fires the entire Alberta Health Services Board. And shortly after that, that's where one of the issues that you maybe have heard a lot about, but I cannot say her name, but the former CEO, Athena Mentzelopoulos, did file a wrongful lawsuit, and this is still on in the courts right now, basically alleging that she was fired for investigating conflicts of interest at a very high level in government. So this is actually still in the courts. There's RCMP investigations into Alberta Health Services and the provincial government for some of these conflicts of interests. The name is skipping me right now, but if you've heard about things like the Skybox tickets, and there's some names being thrown around, but this is, if you've heard of the corrupt care scandal, it's referring to basically what was coming from this. And this wrongful termination lawsuit, and I think a defamation lawsuit now as well, is all in this picture. Okay. All right, so last summer, these 4 separate corporations were created to oversee healthcare. So instead of Alberta Health Services with a provincial health minister, we now have 4 separate corporations with 4 health ministers, 4 offices full of staff, and 4 employers to all of these healthcare workers who used to just be hired by Alberta Health Services. And so actually, I work for a union and was actually called recently from somebody from British Columbia because in BC, they are looking to streamline their healthcare, which is currently split into different sort of corporations, and integrate it into one because it's seen to be a much better model. So British Columbia is going the exact opposite direction of what was done here, and there was really no consultation with any physicians, any public hospitals at least, or anybody that actually does the work in healthcare to do this dismantling. And then this is where, that report comes out for DynaLife. That was actually very recently, just last November, saying over $100 million was just wasted on this, and there were red flags the whole time that suggested they should not have gone with this contract to a private entity for these services. So now we're going to get into the very, very aggressive changes. So at this point in time, people had already been saying like healthcare in Alberta is essentially broken. The cuts have damaged it excessively. This dismantling into these 4 corporations is wasteful and it's chaotic and it's just making things worse. And then Bill 11 got passed, I think it was in a 1-day session with no real debate. So debate was limited so that this would just go through without really getting into the news cycle. And it's called the Health Statutes Amendment Act. And so it introduces these broad freedoms to deliver privatized care. So it's again entitled Bill 11, the same name as the bill way back 15 whatever years ago that basically was alleged was a breach of the Canada Health Act and reduced some of the transfers to Alberta. I'm going to talk more about this act in a second because it is very, very significant. Another one was released a few months ago in May, Bill 29, the Health Statutes Amendment Act 2026. So this one allows access to private preventative testing. So like any sort of diagnostic testing that you can get privately, which you always could do. I'm on a 2-year wait list for an MRI for my shoulder, but I could get a private test in like a week, probably for a couple $100. But you need to have a referral to get those private tests, right? It's been viewed as this way to jump the line. So the big thing about this bill is that you don't need a doctor's referral to now get this private testing. So the private testing right now is already just sort of taking resources from the public stream, and to shorten this line, it does make that line longer. But now you're going to have people that don't even need a doctor's referral going and accessing this private testing. It is just more resources from the public stream. And for people that are maybe it's not that hard to get a doctor's referral is kind of what I'm saying. So it is going to be largely people that their doctors do not think that they have a reason to go and get that test. So last month, actually just a few weeks ago, there was a legal opinion that was published that says that this Bill 11, the original Health Statutes Amendment Act from last year, from November, is a breach of the Canada Health Act. And, oh yeah, so skip the next slide because I duplicated some and I'm sorry. So I want to talk, could go to this one, yeah. So a little bit about like the restructuring. So I did grab these two slides here from the director, Chris. And so this is sort of an idea of what AHS looked like. So we did have it broken into these 4 sections, and it's kind of small, so it's hard to read, but we have primary care. So that is like your general physician or general practitioner. Acute care is like hospital or emergency services. Continuing care is like long-term care supports for and like hospice or just like if you need to have significant care in like a home. And mental health or addiction care. So that's always been considered sort of almost a social service and slightly adjacent to healthcare, but it's still in there. So these were categories that existed in Alberta Health Services, but they all answered to the Minister of Health. They were all integrated with each other because there's overlaps for everything, of course. You know, if you're in one system, you can very easily be in another system at the same time. And it was very basically simple and communicated with each other and easy to follow. So this is Chris's slide on the deconstruction. So basically they've taken those 4 sort of pillars of healthcare and make them into these 4 separate corporations with 4 separate ministers. And it's a massive duplication of resources. And now we have these healthcare systems that aren't talking to each other directly anymore. Workers actually don't even know who their employer are. They don't know who they answer to because they've now created these wildly separate branches of like chains of command. So it's essentially just created chaos, and it's still not figured out. So again, I said I work for a union, and like a lot of these employees like don't even know who they're going to be bargaining with in the next session because they don't know who their employer is. It used to be AHS. Now it's one of these 4 things, but a lot of these workers work in different systems at the same time. So how do they have a specific employer? So now they're going to have to only work in one of like these streams, which is bizarre because like it's just, why would you separate that? But it essentially has been just chaos. And I was in a meeting, a discussion of, you know, a group trying to devise a new healthcare plan. And in this discussion, it was a lot of the union leadership that have workers in healthcare. And one of the questions was, are there any good elements that are coming from this restructuring that we could maybe use? Because like, you know, we don't want to just blow something up if there might be like some good elements. And the answer from, so Sandra Azakar, who is the leader of AUPE, the president, she was actually a previous director of Friends of Medicare before Chris, and she's been a healthcare worker her whole life until getting more involved in this side of things. Her answer was a very quick and loud, no, nothing, throw it in the garbage. So that's kind of the view from most, at least, workers and frontline people as far as like what these changes have done. And something else that you'll notice is that every fall or early summer, Alberta has released its financial report. It says how much it's spent on things. And what they have basically said is that there's been too much chaos from this restructuring that they weren't able to release the report. It's not going to be released till like October, let's say after this referendum. It's not going to be released until late this year because they can't figure out where the money has gone. So it's not been necessarily efficient or even well implemented, and like this is an acknowledgement from the UCP that this has not gone particularly well. All right, so I want to get into Bill 11. Basically, it does a lot of things. It's an omnibill. It has a ton of changes, and there's been a lot of things. It's like it's just going to make our healthcare look more like Quebec's, I think there's been a lot of intentional miscommunication around it, just saying it's going to allow private practices like in Quebec. We've had private practice in Alberta since before 2011, right? Those changes, or was it 2000 when the original Bill 11 was passed? The changes that were brought in from that original Bill 11 many, many years ago was to allow private surgeries that were already happening to now be able to have overnight care. So minor private surgeries were already happening. People were already paying out of pocket for these. This has been here for a very long time. So this argument that we're just moving to allow private surgeries like Quebec has and like some other provinces have, like, no, we were the first to do that. This has been going on forever. This isn't what Quebec or any other province has. There's two really aggressive changes in this. So one is that it allows dual practice, and that is not allowed anywhere in Canada. Dual practice is that a physician or a surgeon can work in both the public and the private stream at the same time. So we know that there are private surgeons that are offering private surgeries, but they are not allowed currently to also work in the public system. And largely because there's massive conflicts of interest to that, in that if you're acting as this consultant on a patient, so let's say I were to need a shoulder surgery. I don't think I will, but let's say I were to, and I would see this specialist or a surgeon, and they look at it and they say, great, yeah, you need a surgery, but it is about a 2-year wait list to get on the public system and have the surgery for free covered by Medicare. However, I'm also a private surgeon, so I could get you in next week for $15,000. So that's a big difference between having a public surgeon say, you could go to the private system over there, that other guy, because I'm not going to profit from referring you to another surgeon. So that is a big difference in that it's going to incentivize these physicians, because yes, most physicians are not, ultimately greedy and in it for the money, but the reality is it's there and it's an incentive, and it's going to impact the way that they deliver options for treatment to patients. If one of the options they deliver puts 20 grand in their pocket, and the other one doesn't bring them anything, right? It just brings them work that they're already going to get paid for. So it's going to impact that, and as far as I understand, they have put out the regulations for this, and there's no real guardrails on that. So many countries, almost every country does allow dual practice, but there are very significant guardrails, and their healthcare systems are very different than ours. So it is a significant issue. One of the other main issues of this is that we are the only province that is going to allow this, which means that while the entire country, Canada, has a healthcare shortage right now, a physician and a surgeon shortage, now across the country, all of these physicians or surgeons are going to be incentivized to come to Alberta, and it's going to put pressure on those other provinces to implement the same rules. Canada, quite simply, is just not producing enough doctors. We produce about just over half of what the average is for developed countries per year, per capita. So this is a significant problem. So that's going to be one piece. To me, the more damaging piece, though, is it's going to allow private insurance to actually cover, to provide coverage for you to access what should be public health care through a private system. So now you'll go to this physician who is offering to do this surgery for you for $15,000. If you have this private insurance, it can cover that necessary surgery for you through the private system. So it is absolutely creating a second tier. And again, I said, repeatedly, I work for a union that represents healthcare workers. A big problem with this is, what you see in the United States is that unions and employers start negotiating this into their agreements as part of a compensation package. And as soon as one big union like CUPE or AUPE negotiates this into some agreements in Alberta, it's going to be a domino effect, and it's going to become this requirement that unions are expected to negotiate this private insurance. And so you're going to all of a sudden have 60-70% of the population having private insurance for the second stream of what should be public health care. And all it's going to do is take resources, because we have a finite amount of resources for these two streams, so more resources are going to go into the private stream, and the public stream is not going to have the resources, but somehow have shorter wait times. So this is kind of the issue. Yeah. So to me, that is significantly the bigger issue. This was taken down, but there was a period of time where the website that was announcing these changes, the government website stated that it wanted public health care to be last resort for people to access care in Alberta. So I think somewhere I took a screenshot of it, but it's definitely down now because that is a full-blown breach of the Canada Health Act. But that was the plan, so last resort. There is no country aside from the United States that has any form of universal care where the public system is viewed as last resort. So just to kind of be clear on that. But yeah, so those are the two main changes. There's a ton of other like weird changes in there where the water gets very muddied on what the definition of a hospital is. So it starts to allow this definition of private institutions to be a hospital. And what services a hospital provides. And I think we're seeing some of those pieces actually have come in with the changes that were dropped a couple days ago. So there was an announcement of some of these regulations that were coming in. And there was a lot of confusion because one of it said that diagnostic or preventative testing would be delisted. And I think it's part of this, like this is a hospital service. So it would be delisted as something that was insured by the province. However, the definition, if you go into this document of it, was not as nefarious as what it sounded like, but like there was a big blow up on the internet yesterday because it sounded like they were just like removing preventative testing from being insured. I don't think that's actually what's happening, but it seems like it's going towards that. All right, I'm gonna grab some water. All right. So just to do like a little bit of an overview of the healthcare in Canada, I don't know, how much time do I have? Oh, okay. All right. So after this, I have like a grab bag of different countries to kind of look at different healthcare systems. But just to sort of start, we have like healthcare in Canada. So there's two real models of universal healthcare. So there's what's called the Beveridge model. So this is what Canada has. This is what the UK has. This is what Australia has. But basically, healthcare is publicly financed through taxes. So exactly what we have here in Canada. So just some statistics on healthcare in Canada. It is ranked 4th in the world by this website or by this like institution called CEO World. So it's not a particularly progressive institution, but it does rank Canada's healthcare 4th. And it has this like healthcare index, which is something that measures the quality of infrastructure, the quality of like physicians, equipment, etc. Access to medicine partially includes the cost of accessing any sort of healthcare and readiness in an emergency situation. And when they're referring to healthcare, they are referring to the whole package, which includes like toe to head healthcare, teeth, eyes, everything. All of that is considered healthcare. And as you know, when healthcare was implemented as part of the Act, it was supposed to at some point include dental and vision and all of these other issues. It just kind of has only barely happened in the last couple of years. So the average cost of healthcare per capita in Canada was just over $6,000. So this was in 2022, which is the last year where they've sort of been able to compile metrics for most countries. And something I want you to realize with that $6,000, $6,100 figure, we in Canada, we have to compete with the US for physicians and nurses, right? So the salaries that we pay here to our physicians are quite high comparatively to most of the world because we have to compete with the United States. In the US, like a lot of nurses can make like $180,000 depending on if they're like in private hospitals. So we compete with that. And so it does keep our costs a little bit high, but despite that, that isn't super high. I'll show you some of the other countries, and we have the 4th ranked healthcare system in the world. So in Canada, what we also have is something called complementary health insurance, and most of us have it. Again, we negotiate access to care for a dental and eye care and other aspects of our healthcare that are not covered by the public system. Access to mental health supports, for example. So most of us actually have this, and it's called complementary private insurance. So what the complementary refers to is that it offers you access to healthcare that is not covered by the public system. So like all the things that aren't covered in the Canadian public system. Another example of that is sort of like top-ups to what is covered. So if you're admitted to a long-term hospital stay, you'll get put in a room and you might have 4 people there along with you. What you might get through your private insurance is a single room, right? A private room. So like it is sort of the same thing, but it is a different and sort of better version of the same thing, but it's not the same thing. So that's what complementary private insurance is, and that's what almost every other country actually has, is this complementary private insurance that sort of tops up the existing insurance. So I'm gonna go just through the closest comparators, but the United Kingdom, who we like modeled our healthcare after, they have a very, so their HCI is like 47.15. There's only a cluster of countries that are in like 70 or above. And then after that, most of them are like 50s and 60s. But UK is like 27th ranked healthcare. They do spend a lot less on healthcare per person. And that is a total cost. It includes out-of-pocket costs as well as covered costs. But my guess is one of the reasons why it is cheaper per person is because they brought in dental care. Dental care was a huge issue in the UK. I remember all the jokes from when I was a kid of the UK dental health system, but they have brought in particularly needs-based supports for dental care, and that likely massively reduces costs of actual emergency care, because you're going to have less people with very severe dental issues, which can lead to bigger problems. Only 12% of residences in the UK have some form of complementary private insurance. So a lot of people will point to the UK and say, like, well, they have this extra insurance. They actually have less people with this extra insurance than we do, and their insurance covers more than ours. So the other comparator I want to do is Australia. And so this one is a really significant one because this is very much the model. This is really the only country that has the model that Australia is proposing, or sorry, that Alberta is proposing. I'll start with an A. So Australia actually has a slightly higher ranked healthcare system than Canada right now. They are spending a lot more per person on healthcare. So that's about $600 more per person. And think about that, because look at where Australia is located geographically. They are not competing for resources the way that we are in Canada, with the United States being just underneath us. So they don't have doctors getting trained in Australia and flocking to the US at the same rate that we do. So despite that, they still have a higher per person, much higher, almost 10% higher cost for healthcare per person. And I think the population is like similarly sized. It's a similar demographics to Canada, similar geography, similar population. They're paying a lot more because they have this system where everybody has access to Medicare, which is like our public health care by province. It covers most treatments like our health care. But then what they have is something called duplicative private health insurance, and that is the model that Alberta wants to move towards. So that is where it creates a second stream of the same services through a private system. And they offer insurance for this, and more than half of the people access this insurance. So this second stream is intended to queue jump. It is intended to offer the exact same services privately, but so these people can get ahead of the line, and somehow them getting ahead of the line is not going to push these people back in the line. Because at the end of the day, if they had finite resources, it is all one line. So if with two different colored groups in it, like the red public people and the blue private people, they're all in the same line. It's just the private people get to jump ahead. That does push the public access people back. And you can actually see that, so these stats were taken from the Parkland Institute, is that it has not decreased public wait times at all in Australia. So these are the comparators to Canada. And keep in mind, where Canada's costs are, it has also been with a lot of ideological attacks on our healthcare system, governments who are doing chaotic things like completely restructuring healthcare, knowing it's just sort of a waste of money. But yeah, if you look at the cataract surgeries, coronary artery bypass, hip replacements, and knee replacements, there's longer wait times in Australia for all of these major surgeries, despite them having this model that we are in Alberta are sort of train wrecking towards. So it's a lot more money per person and a lot longer wait times for the public system. And they are basically at a breaking point in Australia right now where there's sort of mass debate of what they're going to do with their healthcare system. And they're likely to move one of two directions. They're the closest to the US right now. I would say they're probably going to either move more to the US style or more to the Canadian style. But they're at a place where they need to make a choice. I might just do like one more. I'm going to really quickly sort of skim through. The other ones that we do get compared to a lot are, so this other system, it's called the Bismarck system. So this is where most of the care is privately offered. So hospitals are private, physicians are private, everybody is their own little private business. But health insurance is mandatory for the population. They are required to purchase it, and it will typically either come from their employer, and maybe it will come as part of that compensation package, or it might come out of like whatever their social service supplements are, but everybody is required to pay it. One way or the other, and it might get like subsidized if there's no means to pay it. But everybody has to have some form of insurance. Those insurances are that private insurance. It offers some sort of choice, but they're very heavily regulated by the government as far as what they cost, and they cannot deny people that insurance based on any sort of conditions that exist, because everybody is required to have the insurance, so that insurance must be offered to everybody. So typically with these systems, you have this sort of basic level of mandatory insurance that is very similar to what Canada has. And then you can sort of top that up into this like private health insurance model. So I won't show the slide for the Netherlands as well, but it's very, very similar model to Germany. So again, that basic insurance generally covers more than what we cover here in Canada, like a lot more mental health supports, prescriptions, dental care than we cover here. And again, that private health insurance is mostly, I think that I wanted to say complementary. Mostly what it does is just add sort of like top-ups to the insurance provided. So it would do things like, like private hospital rooms, cover some of the gaps in dental coverage. So it's not really, creating a second tier because it's already more of like a private model. So these are the systems that exist. You can see that they're ranked not a ton lower than Canada. So Germany is ranked 8th, and I'll show you the Netherlands is ranked 7th in the world. And they are both actually run slightly cheaper than Canada's. Well, actually, I think Germany is a touch more. The Netherlands is a touch less. So it's a completely different model than what we have, though. It's a model where I think that maybe was the direction that we were headed with our goal of sort of privatizing hospitals, privatizing surgical facilities, and then sort of making this like mandatory healthcare requirement where you can choose your healthcare provider, but they are so heavily regulated that they're all basically actually the same thing. It's like an illusion of choice, but that's sort of what free market's like. The absolute last one I want to cover is only because like I was at an event and was trying to talk to people about healthcare, and somebody came in and said, well, what about Singapore? So Singapore is viewed to be the most economically free country in the world, which a lot of people have interpreted that to mean is the most capitalist country in the world, but it's not actually the most capitalist. It has the most economic freedom, which means like you get to choose how the money you earn is spent. And it's very similar to the systems I just described in that there's this mandatory national health insurance, and you get to kind of make your choice of which of those insurances you provide. So it's a bit more freedom of how you spend your money compared to, say, Canada, where those taxes are taken from you without your choice and spent on healthcare. So now you get this illusion of being able to choose a healthcare insurance provider, or if you want to like top it up. But they have a lot of like absolutely mandatory things that you're needed to do. You have a mandatory healthcare savings fund that takes about 10% of your wages and puts it into this like fund. So while this like mandatory national health insurance covers a percentage of healthcare, you now get this fund that's like 10% of skimmed from your wages, but you now get to choose how to spend it on your healthcare. So it's still freedom. So most residents in Singapore still have this top up of private insurance. And so it complements, again, that mandatory insurance. It fills those gaps of what the mandatory insurance doesn't cover, because it is just sort of like subsidies, and it does like, nicer things like private rooms, etc. Something that's really interesting, I think why people like to tout Singapore as this example, is because even though their healthcare system isn't ranked super high, it has amongst the best outcomes for healthcare in the world. And it's significantly cheaper than Canadian healthcare. And their salaries, if you look at what people are making, Singapore is a very wealthy country. Their physicians are making about the same, if not more, than what physicians are making in Canada. So they have these absolutely terrific outcomes. So this was touted to me. So I did a lot of research because I was like, what is going on there? So what is actually happening is that, first of all, Singapore is a city-state. So the population of Singapore is 6 million compared to Alberta's 5 million. The size of Singapore is about 80% the size of Calgary. So you're taking the population, more than the population of Alberta, and putting it into smaller than the city of Calgary. And so population density makes healthcare easier to deliver, first and foremost. That's a pretty obvious factor. But while these rankings love to tout Singapore as being the most capitalist country, it actually isn't. While you have a freedom to choose where your money is spent, that's not actually what capitalism is. The Singapore government owns something like 40% of private enterprise. So it has investments in private enterprise everywhere. So it's actually a very socialist country. And that makes it very wealthy. And that's why it's able to pay its physicians. But it also owns something like 90% of homes, of residential buildings. So, and they're publicly offered to people. But what that's allowed them to do is sort of engineer the way that the city looks. It's allowed them to create a city where people basically are heavily disincentivized to drive. It's super inconvenient to drive. Public transit is heavily pushed and very accessible. And the city was designed so that people have to walk like 20 to 30 minutes a day at least to get anywhere. So they've basically physically engineered the city to make people more active. And we also know culturally, Singapore is in a part of the world where it is more community-based than individually based. And we saw during COVID, countries like Singapore or Japan, people were just putting on a mask on day one to basically protect their community versus the amount of resistance that we were seeing in countries like the UK or Canada or the US. So disease does not spread as quickly in these countries as they do here. And another really interesting thing they do is they provide grants to young people that live close to their elders. And which is, again, it's going to reduce a massive cost of healthcare, which goes to the elder population, because when they're young people living near them, they're just going to stay healthier in general. They're going to be more active. But if medical issues arise, they'll be seen faster because their grandkids live near them or their kids live near them. So they have all these sort of social projects that are designed to be preventative in just making people live more healthier lifestyles. And it's a very government regulated country. So I know they love to tout it as the freest country in the world. It has economic freedom, but it is a very engineered and weirdly socialist country despite that. And that's sort of why they have such amazing healthcare outcomes, is because people just don't need healthcare as much there. It's not because their system is better than ours. So I wanted to end on that, just to argue with that guy I saw 3 months ago. But the reality is that Australia is the only country that we would really be moving anywhere towards. It's the only one that's comparable to the plan that's being implemented. Of course, the United States. I didn't even include it in here. Does anybody know, compared to Canada, what is the cost per person for healthcare in the United States? It's almost exactly twice. Yeah. It's the highest in the world by far. The second most is Switzerland, which is the only other developed country that doesn't have any sort of universal healthcare, right? So the more privatized it gets, the worse and the more expensive it gets per person. So that's sort of the moral to take from this. Canada does have the most restrictions on access to certain public healthcare, but we also have less access to things like dental care and eye care and things. So we're doing quite well for those things that we do provide. But yeah, that's kind of where I wanted to add it, because Australia is the best comparator and they're doing worse than us. So let's not move to a country that's doing worse than us. Anyway, that's that's my talk. I'm sorry if it was very dense, but I do research, so yeah. All right. Are there any questions? Questions? Yeah. The 4 corporations are implemented. They were actually created last June. They were created. They exist. So you can actually you can start to look at any collective agreements that have been settled, and you can access those publicly. They've now been settled not with the Alberta Health Services. You'll start to see a different employer name. So it's one of these like Acute Services Alberta or anything. So if you're in a hospital, for example, your employer is now Acute Services Alberta. So they exist and they've been created. I'm gonna look that up. I don't remember, they're very medically sounding names. I'm not gonna have internet here. I don't remember the exact names, but one is acute services, which is hospital care. One is like long-term care. It might just be called that. And then there's mental health and addictions. And the other one is supposed to be like the preventative or like
Primary
general practitioner care.
It's primary and prevention.
Primary prevention, yeah. Okay.
I have such a fascinating interest in this. I wanted to point out that and many of you know, I've been through the orthopedic system for a long time. When I look at orthopedic surgeon web pages, it's easy to find them associated with a private clinic already. So the structures are in place to do the private surgery.
Yeah.
Some of my orthopedic surgeons have moved into bigger facilities, and the private surgeries right now are for WCB or out-of-province people or RCMP who have a different structure and access to health care than under the Alberta health system. So I just wanted to point out those structures are there. They're just that little nudge from the government to get them in place. They're going to be in full bore movement.
Yeah, and another piece I didn't mention was because now physicians can work in both systems at the same time. It used to be that like at the start of your career or at some point, you had to make a choice if you're going to be in that system or if you were going to be in the public system. But now what you're able to do is sort of like dip your foot in and maybe like take some part-time work at one of these things. So it makes it so much more fluid how people are able to move between the two systems. So it's taken down a guardrail that's going to prevent just people from easily going into the system where they can make more money on surgeries. But yeah, it's like the system already exists. A ton of our surgeries, and like you can see it in the way the budgets have been released, is they've been allocating a lot more money and wanting more surgeries to be done in these private facilities as opposed to in public hospitals. And they've been sort of allocating specific resources, specifically anesthesiologists are being assigned to the private system. And we have a severe shortage of anesthesiologists. And so the public system has had to cancel surgeries because their anesthesiologist is working in the private system because they've actually been assigned by the government, because right now the private system is largely still funded publicly. But that's probably going to stop soon. Yeah.
Two questions. First of all, about the stats comparing countries. Do they take into account climate? How many people in Canada are injured every winter by walking on ice?
Oh, that's
Singapore
interesting.
doesn't have to deal with that.
Yeah, and for that you would probably be most closely looking at like Sweden and the Scandinavian countries, I think, and their costs are generally higher than ours, and for significantly worse outcomes. And that's not worse outcomes, I should say, but for significantly like lower rankings of their healthcare system. I think it's like Finland. I did have a slide in here, one of them. I think Sweden pays a roughly similar to us. I think it's Finland or Norway that pays about $8,000, $8,500 per person for healthcare compared to our $6,100. And I imagine that is probably a factor, is there's just a lot of healthcare issues, not even just related to like slipping on the ice, but just like living in colder temperatures. It reduces your immune system. So.
Okay, thank you.
Yeah.
And the second question, is there anything that all of us can do about improving the situation?
Okay, actually, and unfortunately, so I brought a bunch of information at the back, including like if you want to get involved with Friends of Medicare, so there's some pamphlets. The number one thing you can do, and I want to go back to saying that Stephen Harper's Conservative government said no to those 3 directions. The first direction I mentioned has already been in place aggressively in Alberta of shifting most things to private facilities being contracted to do public surgeries. The other 2 directives are exactly what the current Bill 11 does. So when Stephen Harper's Conservative government said, no, we're going to cut your healthcare funding. So right now, Friends of Medicare, the Canadian Labour Congress, the Canadian Healthcare Coalition are all aggressively, they were in Charlottetown, I think yesterday or this weekend, the past couple days for the Premier's meeting. They are lobbying the Premiers, and they're lobbying the federal government, which is a Liberal government right now. And in this riding, we currently have a Liberal MP, Corey Hogan, whose father was a physician and is very proud of the public healthcare system in Canada, and I've talked to him. But we're trying to push the federal government to step in and say this cannot happen. So a legal opinion has already been formed saying this is a breach of the Canada Health Act. We don't think that any sort of pressuring the provincial government is going to do anything, and we think that the way to get this resolved is through action of the federal government and lobbying Carney and lobbying the Liberals and saying, like, you need to enforce the Canada Health Act. You were elected on a progressive platform allowing like our healthcare to, it's not going to just be Alberta, right? We know it's not going to just be Alberta. It's going to trickle out to the other, it's going to have to trickle out to the other provinces. I'm basically saying, like, you need to step in. If Harper stepped in, you need to step in. So, yeah. So contact your MP, Corey Hogan.
Okay.
Yeah.
Anyone else?
Specialists under the Alberta system are only allowed to draw a certain, to work, to do a certain amount of work. And I heard one story about a cardiologist whose limit was quite high, and I'm thinking, oh, hey, this system was built for doctors like him. In the new system, are they going to lower the amount that he can draw, that he has to draw from the public, or the amount of time and work that he has to do in the public system under the new system?
So there hasn't been any like talk to my knowledge of changing the number of like surgeries or treatments that can be offered by a specialist. I know some of those numbers are fairly low, and particularly like for MRIs, for example, the number that can be issued per month is very restrictive because it costs too much, and that's why like I have such a long wait time. So I haven't heard anything on changes to those numbers, and it is supposed to be that you meet your publicly funded number, and then after that, you're allowed to offer things privately. But like, to me, why can't you just do more publicly, right? So that is something probably that would be really useful to keep an eye on if those numbers start changing. So, anything else? All right, so yeah, I can't stress enough, like Friends of Medicare, it is a complete nonprofit organization. I am trying to push them to bring a support staff person down in Calgary, because as we know, Calgary is going to make or break the next election, and Calgary is the city that is able to influence what parties actually implement following the election. Like, so I'm trying to lobby them to bring somebody down here, so anything you can do to support them or encourage them to be more active in Calgary, so it's not just me doing everything on top of my full-time job, that would be great. And then the other piece is again, really, I can't stress enough, especially if you live in this riding, Calgary Confederation, to contact Corey Hogan and say that this is something that concerns you and that you would like to see the federal government act on it. So that would be my parting words. So, all right. Thank you.
I just want to thank Kira for coming and bringing us her wealth of knowledge and understanding of the system. And like I said before, she is kind, caring, responsible, and honest, and very hardworking. And I hope that you've learned a lot today. And I hope you all will start pandering the feds to get on this, because when Klein did it back in the early 2000s, I remember it very clearly, and it was like almost instantly. Soon as Klein, he had maybe a month at the most, and the money just stopped. And then it was things were normal again. Thank you. Thanks, Kira.